Ophthalmology Foundation and the All India Society, Ophthalmological Society, for the opportunity to have this space where we can speak and explore and think about health professions education. Thank you so much, Professor Mina, for having me involved so actively. Well, I think this is not the right one. This is for after the, okay. Just a little bit of a spoiler for the afternoon. Okay, so this is the correct one. Yeah, please. Yeah. So, so the goal in objectives, in this builds on the marvelous presentations of the exceptional presenters before, is to appraise the importance of the threefold structure. So we will be focusing on the structure of a session of simulation-based education. So we have seen some techniques before to give feedback, and also the importance of building a wet lab. And now we will focus a little bit, zoom of the session in the structure of that session. So explain the rationale and the process of pre-brief, create outcomes-based learning by simulation, and explain the rationale and process of debrief. So a primary aim of healthcare simulation is to keep patient safety, and by that to engage learners in applying knowledge to activities, rehearsing clinical skills and behaviors, and this builds on the previous presentation on the importance of building a structured wet lab, and ultimately to learn for the learners themselves, to learn, demonstrate, and maintain new knowledge and skills and attitudes, because this is not about just, when we speak about simulation-based education applied to surgery in ophthalmology, it's not about just only the procedural skills, but also the way that we behave before the surgery, the pre-consultation, the surgery itself, how we relate, not only how we proceed as surgeons, but also how we relate with the team in the OR, and afterwards, after the surgery done, the post-op care with the patient. And for all that, it should be included in a thoughtful and holistic wet lab program. So what we aim is to improve, to keep patient safety, I would say, because it's not about improvement, it's about maintaining patient safety, and also build competent healthcare practice. So when we design for simulation-based education, of course, we have the learning activity in mind when we have those sessions available for the residents, fellows, already practicing surgeons as well. For new techniques, we keep learning. We are lifelong learners as we practice. But we also must take importance to the pre-brief, the moments that precede the learning activity in itself, and the moments that will follow the learning moment as the debrief. And we will speak a little bit about these three moments of a simulation-based education in a wet lab or simulation environment. When we speak about pre-brief, what we are speaking is about communicating very clearly to the faculty, to our colleagues, but also to the learning community that includes the participants, the learners, residents, fellows, practicing physicians, ophthalmologists, nurses, whomever is there to learn exactly what is expected from them to demonstrate after that session or after the program that can comprise several sessions, to demonstrate afterwards as a result of practicing and having this program. So this should be an introduction that should be fluid in terms, it should be side by side. when we spoke some minutes ago about flipped classroom, we could see the teacher as a facilitator, not so much as the sage on the stage, dominating all the information, all the wisdom, all the knowledge, but someone who is willing to learn as well and has some experience and should lead the group to the outcomes that are predefined at the outset of the session. Then we also aim to create a safe educational environment, and by providing this, by creating this atmosphere with the learning community, with the faculty, with the facilitators, with the experts in content, those who are more expert, for instance, in some surgery, some surgical skill, the facilitators that will be there also to help the learners to attain the outcomes that were predefined, and the learners themselves, so that learners can be appropriately challenged according to their level of ability. And now we are thinking about the needs assessment that we should have conduct, and should also, this is an opportunity also for assessing what our particular group would be more interested to develop. So there's a basic assumption when we are speaking in this moment of the session, the simulation-based education session, that we believe that everyone participating in simulation activities is intelligent, capable, cares about doing their best, and surely is there because he or she wants to improve. So the idea is for the faculty to bring the group to the best as they are capable of to attain after the session or the program itself. So prepare the learners for the simulation that will come next, reduce their anxiety, promote psychological safe. So it could be kind of saying that we are ice-breaking the session that will follow. The design ensure constructive alignment, so learning activities should meet the identified needs and align with learning outcomes, should be constructivist in terms that by knowing that, we know that our community of learners will build upon their previous experience, and we had a marvelous presentation lecture about adult learning principles that surely apply here. Write clear learning outcomes, learning objectives with appropriate level of challenge that learners could feel that they will be leaping for the next step in terms of their knowledge and skills, and so they will be, what I mean is that these learning objectives will be attainable by the group, so where they are and leading to the next step. And plan developmental feedback. This is to speak that it's very important. It's good for the learners to go to the simulation wet lab center and practice by themselves, but this doesn't replace a structured program that includes the experts in content, the experts in the particular field of surgery that we are conducting the program on, and also to be there and give immediate and good constructive feedback for the learners. This is just to say that also we should be progressing about these several steps of Maslow's hierarchy of needs in terms of our pre-briefing. So we can be, for instance, when we are working with practicing physicians or those who had, for instance, a leave for an illness or a maternity leave or something like that, and would like to perfect their skills and be more self-confident about the surgery, for instance, they will be probably a little bit higher in this hierarchy. Whereas, for instance, for the residents of the first year who would like to start in their surgery, first steps of cataract surgery, for instance, it will be a little bit different. So this is just to say that we should know very well our audience. Assure confidentiality, so this is not something that would be to be speaking about afterwards with people who would never had any part of this program or were here. And so this is for learners to feel safe and in a protected environment where they can train and they can be, you know, bringing up their best. Orientate learners to the simulation environment. Remember that simulation is a social practice, so this is a group. Usually we don't have only a participant, but several participants and a faculty of facilitators and expert, 1, 2 experts in content united. So for the program director, it's very important to think about this and how it will be important to make the group cohesive. And negotiating a fiction contract. So having something that the learners, and probably this would be some kind of a hope for this contemporary learning, is that we have this contract with the learners that they will achieve, that we will make them possible to achieve this and that learning outcome at the end. So we will offer them our presence, our skills, a program, material, tools, so that they can reach this step. And don't rush the pre-brief. This is a very important moment, as well as it is the moment that is following, but this is something that will pave a good learning environment for what's next. Assert the basic assumption, as we said. Adopt a position of humility. I think it's for everyone there to feel that everyone has something that will be different from others and will have the responsibility to collaborate and bring up to the table that experience so that the group, as a group, can evolve in terms of individual development, but also as the group. And this is when we come to the learning activity that should be structured. It should be based on a problem that was found. We should know our learning community, as I said, so the needs assessment is a very important phase. And also create and establish very clear, SMART goals and objectives that will link exactly to what will be measured at the end of the program as the learning outcomes. That should be what the learners should show they are capable, achieved as a result of participating in the program. So this is just to say that learning objectives that connect with the learning outcomes, and learning outcomes will be, if the objectives are communicated as the expectations of the program, the outcomes are exactly the items that will be what we expect the learners to show. And these should be phrased as specific, measurable, attainable, achievable at the end of the program or session, and should be relevant for the participants to apply in practice, and also time-bound in terms of the session or the collection of sessions that compose the whole program. Now the debrief, this is the third part, very important third part of the structure of a simulation-based education session. It is classically described as non-judgmental. It's the moment that after all have had the opportunity to go to the bench microscopes, try out what was expected to be trained, and then come together either in the same room or in a different room, and together speak about the experiences that the group, the individuals have, and also what the faculty has found as well. So should be non-judgmental, should be the heart and soul of simulation-based education, and the participants, the community, should see the facilitator as a co-learner, because the faculty is also learning how to improve their own program by collecting this experience to the next iterations. So the role of the facilitator is very important. may not be the expert in the surgery itself or the concept or the knowledge that is given the heart of the whole session or the program, but should be responsible and feel that responsibility to make the participants active and responsible for their own learning, and ensure that the group also walks towards what was defined by the session and the faculty in terms of attaining those learning outcomes. These are also very important in terms of making this environment as informal and trustful as possible. As you can see, usually having people sitting around the table in a round table so that everyone can see each other and share experiences is usually good. If this is not possible, and for instance, if there's the need to, I mean, this debrief is also coupling the feedback that should be also provided while the learners are trying out during the program itself, during the hands-on experience. So more individually than this whole session group, as you can see here in the diagrams. So there are several models for the brief. If we go into the literature, this is just to say that we aim at the end of any debrief is to capturing what was the best part that learners have achieved and what were the aspects that could be considered as areas of improvement. And this can be done also. We can ask for the learners to think a little bit and write what they felt about their experience, write, for instance, carrying a blog or in a logbook or a portfolio, for instance, for a longitudinal program, should be facilitated in terms that this is very interesting to say, but facilitators should be there. Faculty should be present also in these moments to help the learner to bring up and reflect and conclude what is the best that he or she has attained and what could be improved as well. And for instance, also video playing back, and this can also be done in practice simulation programs, as we can see, record that practice and then comment that practice with an expert or a facilitator. So the idea here is to, what have I done well? What have you done well? But most important is to inculcate, to integrate this culture on the participants, to think about what do I think I have done well? What do I think I can do better? And then compare and contrast this opinion with the opinion of the facilitator. So these are several models, how we can phrase in terms of approaching non-judgmentally, with humility as facilitators and faculty, and be together with our learners. And sometimes opinions do not level. The facilitator thinks something that is not exactly what the learner thinks. And this is also some way to phrase our conversation as we see here. I'm hearing two slightly different perspectives on the way the team approached, the team or you approached something. Here is airway management. Well, let's spend some time reflecting on how and why this happened. This is something that shows that our openness from the facilitator, from the faculty, to reflect about this, and also understand from the side of the learner what make the learner think what he or she thinks happened and not exactly what the facilitator thought it was. In summary, simulation-based education experiences should be carefully crafted around these three important stages: pre-brief, learning, and debrief. Pre-briefing should be intentionally designed to create a psychological safe space to maximize learning. Simulation-based activities expectations outcomes, learning objectives should be clearly communicated. The brief is a special feedback moment. It's a process that, while maintaining a safe learning environment, may uncover emergent learning gaps. Thank you so much. This is a collection, this is endorsed by the Ophthalmology Foundation, that were produced by the committee, the subcommittee of simulation-based education. You are most welcome to visit. It's published and it's all about simulation-based education. Thank you.
Thank you. Thank you so much, Dr. Helena, for that in-depth look at simulation. Is it still something new for our country, or really it's not anymore? That's something we're going to be debating for the next few minutes. And also, any other tips that you have for wet lab that has worked for you, cost effective? And anything else to engage? Is clinic teaching as difficult as didactic teaching, as we talked about earlier? These are a few points to discuss before we come to the even tougher topic of communication and professionalism training. So we'll pause for about 5 to 7 minutes, take a quick round of comments, and then we will conclude this session, the didactic portion of the session, with Dr. Krishna Prasad's talk. You have a comment, please?
See, wet lab is a very difficult proposition for medical colleges and institutions, is standard thing. But I have few kind of parallel thoughts. Most of our operation theaters have microscopes, which we use for our patients. And it's not occupied 24 hours. So most of the time, it's actually not being used. So if institutions can actually change their policy, they can actually use the same microscope for wet lab. Because they say we have to buy a microscope, we have to have a room. It's not really necessary. If you can take care of the kind of the asepsis part of it, if there can be some protocols and SOPs for that, we can probably use our own operation theaters, few probably hours kept apart for wet lab. This is one suggestion. And second thing is always a financial problem. The institution cannot spend, cannot have the budget for it, and a lot of red tapeism. Presently, all the residents have receive a lot of, money is quite sufficient in terms of their monthly stipend. And they can always do a crowdfunding. There are institutions where there are 10, 20 PGs. If they can probably put up like a share, like you can have a lot of companies ready to give their second-hand refurbished or microscopes of phaco machines. So even few lakhs by crowdfunding, and it can be transferable. Like this year's PG can use that microscope and can sell the share to the next batch of PGs. So obviously it goes free for them. So something like a jugaad. So that is something that, and simulators, I don't know, this is my personal view, people may differ. What you say in Hindi, dikhane ki dant hai, aur khane ki dant nahi. We basically have to work on wet lab model rather than simulators, which are not really cost intensive. I mean, they're very cost intensive and cannot be kind of an equitable distribution for a huge PG population in India.
You have a question? Yes, please.
Adding, sir, I am running a wet lab program for the last 12, 13 years in my institute. We have 3 microscopes. Those that have been condemned, we are using them. Your suggestion is very good. Once the OT is over, we can get the eyes kept in betadine solution for about half an hour or so, remove the epithelium as it got edematous, and the leftover sutures, the leftover visco, the Blorex, the blades, everything is there, and you can do it then and there. Those PGs who are posted in the morning, who has done the OT, and others can have, even the side viewing system is not there, they can have a loop, binocular loops, they can see it in 3-dimensional. The assistant viewing system is 2-dimensional. Even if you have a screen, it's 2-dimensional. But if you have a loop, it's 3-dimensional. That's I did with the loop. I started. Then when I joined my institute as a teaching faculty, then I started a wet lab program, and we are doing this. I think we have a separate wet lab, but your option is also quite feasible, and everything is quite possible. Binocular loops.
So use a loop instead of a side scope, if there is no side scope. A comment from Dr. Akshay, please.
I actually have a different opinion that when you say simulation doesn't work and that it is not cost effective. Did you know last year LVPI trained 88 trainees on the simulator for SICS and now for phaco. And the cost of a trainee getting trained in a cataract surgery on the simulator as per the prescribed simulation training program costs less than a trainee attending the AIOS conference. So cost effectiveness is not something that's and effectiveness, yeah. So we've actually, in LV Prasad, S. Shankar Netralaya and Mahatma Eye Hospital, there was a case control where one set of trainees directly went into wet lab and into live surgery. The other set of trainees operated on simulators, went into live surgeries. The first 20 live surgeries of both groups of trainees were taken, presented to a group of 12 masked surgeons who didn't know which trainee was for which group, used the ICO Oscar to grade the surgeries and also to give a scoring system based on technique, outcome, and errors. There was a 50% lesser number of errors in the group that operated on simulation first and then into live surgery, better visual outcomes at the end of 6 weeks, and lesser surgical time and lesser supervision takeover in the first 20 surgeries. We've not even gone into the financial implication of better vision at the end of 20 surgeries for the patient. So the concept, virtual reality-based simulation especially, is now gone into a level where we are looking at predictive validity, which means looking at a performance of a trainee on the simulator can actually, and grading that performance, can actually help you predict how good the surgeon is going to be in real life. It's reaching the level of pilot predictive validity because you can actually get a license to fly an aircraft without stepping foot in an aircraft. That's good, how good flight simulators are. Virtual reality simulators in surgery are reaching that level soon. So not only is it no longer not cost effective, but it's also extremely effective from the patient's perspective, because at the end of whatever we do, the heart of it is patient safety. So if we look at, I don't think cost effectiveness, yes, in a country like India where resources are low, cost effectiveness is one aspect, but patient safety, I think, trumps all of that.
I don't think it's either or. They both can happen. So wherever simulation is possible, yes, but wherever it is not, wet labs. And even places which have simulation, they can also do with wet labs. So they are complementary to each other.
I think one of the other aspects that will come over a period of time is to really gain the experience of managing complication. No wet lab will be able to generate that, but simulation will be able to do that. The second thing that we have observed with the simulation training is that it almost gives you a feel of you are operating in operating room, because the microscope is there, your hand movements, everything is. I myself did few small incision cataract surgery on simulation, and I realized that I think to a beginner, this is a very powerful tool of giving them the tactile sensation as well as the knowledge about the entire procedure in that environment. The cost may come down over a period of time, primarily because one simulation you can use entire day, almost 6 to 8 trainees per day you can. And this is 1 week of training. That gives them complete experience of any surgical procedure that you want to. Say, yes, it keeps.
Sorry, you finish.
So even if suppose you enter into the tissue and you are reaching the almost premature entry, as soon as you reach that level, it gives you impulse that you are entering. Yeah.
So just to
it is, we had this simulator in DY pattern. It is very useful.
An instructor-led simulation-based training is actually the crux of it. So if there's a dedicated instructor or someone who's monitoring you, what you do, like in the UK, 50 hours on the IC or VR Magic simulator is mandated towards completion of your residency program. But it's unsupervised. 50 hours have to be logged in with you on the simulator. You can actually turn on the simulator, hold your hands on the joypad or have your entry in the logbook and watch about 10 movies on Netflix and come out. You would still be registered because that gets counted as hours logged in. But here, when there's an actual instructor telling you how to do, what to do, giving you feedback, and not only that, you have assessments on the simulator. So that actually helps.
So Yeah, because Dr. Grover and Dr. Helena need.
Your opinion requires not a single penny of investment except for procuring the eyes. Not a single penny. Just 10 rupees, we get an eye for 10 rupees. That's what we
Dr. Grover.
One of the ways of
everywhere, in virtually every college, every OT we can pay.
yeah.
From
So
day one.
one of the ways of increasing cost effectiveness is to have it at community centers where a lot of people can come in and do it. So like the AIO's office now has simulator too. So the utilization can be improved by making programs which ensure the maximum utilization of the high initial cost, which is the constraint which Krishna Prasad is talking about.
A very good point. And Dr. Helena.
I was just saying that taking the the trend of the simulators, probably the price will go down in the future. And what is so exciting is that these machines have themselves something that I have been just trying to get the message across in terms of structure, of being present and giving feedback timely and constructively to the person. You start receiving that directly from the program of the machine, of the simulator. So this is exciting in one way, but at the same time a little bit, can be, wow. So we are completely being replaced in this aspect by simulators. Something that I would like to also bring to the table is about the experience of the simulators that are more and more developed, and we can have the sensation of the haptics, right, of having the instruments and closer to the reality. But exactly, I would like to think with you what you think about the simulators and, for instance, the wet labs with the artificial eyes or the animal eyes, and the differences between both of them, knowing that the simulators in time, they will be equipped with the best of the practices in education. So, but what do you think about this complementation of these two, so the wet lab and digital lab, it's about seeing the videos of surgeries, not so much, but the wet lab and the simulators. And probably in the future simulators will be more widespread, but right now what do you think about that?
So there is a limitation of wet labs. You can teach them only few procedures. On the simulator, that limitation is not there. We can teach them intraocular lens implantation, that ring segment, and all of those things. So, yeah, so I'm sure that going forward, the simulators, every surgeon will have to go through so that they can upscale their. I don't know when last I did anterior vitrectomy, and if that thought comes immediately, I feel shivered that will I be able to do good job if I end up having, say, extensive zonular dialysis. So I think these things will improve, and our capability of managing complications, things that are rare in surgery, will improve drastically.